Thank you for the invitation and also welcome from my side. As already announced, I would like to discuss with you the theme Moyamoya in Caucasians. This webinar is aimed to doctors, neurologists, medical students, caregivers and nurses, but also as well as affected patients and their relatives. However, as we are dealing with a specific topic, patients who already have some prior knowledge are most likely to be addressed than beginners. So let's start.
First, I want to give an overview of the agenda. Unfortunately, we have little time and can only briefly cover the topics listed here. The controversial question of whether or not there is a distinct variant of Moyamoya angiopathy in Caucasians, white Americans and Europeans, has been debated for some time. I will show you the previously unpublished attempt of a meta-analysis on Moyamoya angiopathy in Caucasians. The problem is indeed that in Europe, and even more so in the USA, ethnically mixed cohorts are often analyzed. Only 8 articles were included in the meta-analysis now reported, as most of the other reported ethnically mixed cohorts. The data are compared with 2 large studies from East Asia. What do we know about epidemiology? Epidemiologically, there is little data. Professor Yonekawa and Professor Kahn from Zurich previously reported an incidence of 0.03 per 100,000 in Europe, and there are somewhat higher figures from the USA in an ethnically mixed cohort. A study from Denmark in Europe is based on 80% Caucasians and assumes an incidence of 0.047 per 100,000. This would correspond to 39 new cases per year in Germany and 210 new cases in the European Union. In our analysis of 8 studies, we found a mean age of 31.4, although ages diverged in the Asian comparative studies. In the 8 studies analyzed, the female predominance was clear and much more pronounced than in Asia, at 2.75 to 1. There was even more women in my own cohort. I would like to point out, however, that a high misdiagnosis rate can skew the data. I would like to show you my publication on histology of Caucasian Moyamoya angiopathy. In this German autopsy case, we found identical histology as in Asians, with thickening and corrugation of the inner elastic lamina and fibrocellular thickening and proliferation of smooth muscle cells of the intima. There are significant differences in genetic predisposition between East Asians and Caucasians. Several studies on Caucasians showed that there is no founder mutation, but that several genes are involved in the development of Moyamoya angiopathy. More specifically, the R4810K mutation in ring finger 213 gene, which is found in Japan, Korea and China, is not found in Caucasians. However, in some European families, involvement of the ring finger 213 gene was found altered in a different position. One important finding from the last years is that also in Europeans there are familial forms, as shown in these family trees. The other picture shows that there are many different regions and genes discussed to be involved in Moyamoya disease etiology, and so in Europe we think there is a more heterogeneous genetic region, and this is clearly in contrast to Asian founder mutation.
Now I want to show you how the disease looks in the angiography in Caucasians. We analyzed 155 German patients with 280 hemispheres and found the champagne bottleneck sign in 77.4%, which was similar to 63% in Asia. However, the percentage of posterior cerebral artery involvement was lower at 8.4% in contrast to the data from Korea, where 50% of RNF 213 positive cases were affected. In this German study, we found cerebral aneurysm in 6.5%, which was comparable to 5% in Asia.
Interestingly, the angiographic Suzuki stages at initial diagnosis were similar in our German cohort in Essen compared with Korea and in contrast with India. This may reflect the timing of symptom presentation, but may also show the quality of the healthcare system may influence the timing of diagnosis. The main matter of debate is if disease presentation is different in Caucasian patients compared to Asian patients. Especially it is discussed if hemorrhages occur much more frequently in East Asians compared to Europeans or white Americans. However, I here show you pictures from European patients with an 7 Tesla MRI of a microaneurysm and with a picture of a cerebral hemorrhage. However, as could be suggested from former studies, also our new unpublished meta-analysis showed a predominance of stroke and TIA in European patients. However, I want to point out the high standard deviation. Here you find a table about disease presentation. 200 German patients presented with stroke and ischemic symptoms in most cases. 9.5% had hemorrhages, but also many patients had unspecific symptoms like headache and seizures. It is interesting that also 6.5% had syncope. Now we want to talk about therapy regimens. Of course, we experts in Europe can benefit greatly from the broad Asian experience of the experts. But the question is whether, conversely, experience with Caucasian patients can be interesting for Asian experts. I show an old survey on therapy strategies that showed a big difference between Asian and non-Asian experts, especially regarding antiplatelets. Asian experts and experts outside Asia estimated the risk of bleeding with aspirin very differently, which could be influenced by the different symptom frequencies. Whether this concern is justified is unclear. In patients without bleeding, aspirin is certainly helpful in Asia. Interestingly, there was even more bleeding in the patients without antiplatelets. As recently as 2018, East Asian experts were cautious with the use of antiplatelets. Without claiming that this data can be applied one-to-one to East Asian patients, I want to show you my study about transcranial Doppler sonography with detection of embolism in German patients. In 10% of the German patients, we found so-called microembolic signals that are indications of embolisms. These were highly significantly associated with recent ischemic events. In all patients, the antiplatelet drug regimen was changed and follow-up was normalized. German patients treated with aspirin and clopidogrel also had no further bleedings. Interruption of aspirin intake before surgery was associated with microembolic signals. Given the possibility of different frequencies of cerebral hemorrhage, I don't want to suggest that people in Asia are learning uncritically because of this study, but it could be mechanistically interesting and may also argue for more generous antiplatelets among Asians. Finally, what are the conclusions?
In summary, it is difficult to answer the question from the title. There are facts that suggest that the disease is different in Caucasians than in Asians. These factors are more ischemias, less bleedings, and marked female predominance. This could also condition different treatment approaches. On the other hand, possibly these arguments are based on distorted facts. For example, the high number of misdiagnoses in Caucasians. Moreover, the identical histological and angiographic presentation would argue for a similar concept. At least in Europeans, clots play an important role in the disease. Large studies in Asians are lacking. Smaller studies also suggest this. Overall, I hope I have been able to raise your awareness of the topic, and I'm pleased that this online educational format allows us to exchange ideas over such great distances. Thank you so much.
Please feel free to send questions and feedback to this email address. I want to thank Salman for important support, and I would be grateful if some of you want to follow the German Moyamoya Friends Association on Instagram, or if you recommend some of your English language patients the teaching video on YouTube from Moyamoya Friends Association Germany. Bye bye and auf Wiedersehen.